Welcome back to the Deep Dive. Today, we're taking a look at a health challenge that I think is often seen as just a simple accident.
Yeah, just a slip and fall.
Exactly, but
Yeah.
it's actually this complex intersection of, bone density, disease management, and even pharmacology. We are diving into hip fractures.
That's right. And for anyone who really wants to be well informed, this is an essential topic. Our mission is kind of threefold.
Okay.
We're going to unpack the anatomy of the injury itself, reveal the often hidden risk factors, and some of these are surprising, like common medications, and then spend a good amount of time on prevention and the actual risk assessment tools that are used in clinics.
All right, let's start with a really crisp definition. When we say hip fracture, we're not talking about a bruise or a dislocation.
No, not at all.
We're talking about a break in a very specific part of the femur, the major leg bone. It's a break in the neck, the head, or the trochanter region of that upper bone.
And understanding that exact location is, well, it's foundational. It basically dictates the entire treatment plan and, honestly, the prognosis for recovery. Anatomically, we break them down into two big categories.
Based on where they are in relation to the hip joint capsule.
Exactly. So you've got the in and the out crowd, so to speak.
Let's start with the inside.
Okay, so first you have the intercapsular fracture. This happens at the femoral head and neck, which means the break is literally inside the capsule of the hip joint.
And that's a problem because of the blood supply, right?
Precisely. The blood supply to the bone is right there inside that capsule, so these are particularly worrying.
And the other type.
That would be the extracapsular fracture. This one is outside the capsule, usually in the wider, stronger parts of the bone called the trochanter regions.
So a bit further down the shaft of the bone.
Right. And because of that, they generally maintain much better blood flow, which is just crucial for healing.
So different location, different complexity. Now, how do these breaks even happen? For a healthy younger adult, you'd think it takes a lot of force.
No, immense force. We're talking about severe trauma, a car accident, a fall from a really significant height. You're trying to break the largest bone in the body.
But that's not the whole story.
Not even close. And here's where it gets really interesting. In older adults, especially those with osteoporosis, that force required just plummets.
How much?
The bone can be so fragile that a fracture happens with almost no trauma. We see cases where the bone breaks first, just from the person standing on it or twisting, and then they fall.
Wow. So the fall is the result of the break, not the cause.
Exactly, and that's a critical distinction. It changes the conversation from a trauma intervention to a bone density crisis.
And just to be complete, for children, it's rare, but it's almost always high trauma events again, right?
Yeah.
Sports injuries, major falls.
Right. Or sadly, in some cases, physical abuse. But if we connect this to the bigger picture, most sources really focus on that underlying fragility. The greatest risk factors are simply old age and most powerfully osteoporosis.
The numbers are pretty staggering when you look at them.
They are. 2/3 of people who show up with a hip fracture already have osteoporosis, whether it's diagnosed or not.
And the demographic focus is so sharp. The data shows that 75% of all hip fractures occur in women after menopause.
That one number really says it all. It just underscores the profound impact that the loss of estrogen has on the entire skeletal system.
But it's not just about age and bone density. There's a whole clinical picture to look
A
at.
huge picture. I mean, yes, a history of falls, poor muscle tone, being underweight, those all play a role.
And then there's this list of other diseases, comorbidities that increase risk. It's fascinatingly broad.
It is. You see things like Cushing disease, hypothyroidism, type 1 diabetes, depression, epilepsy, Parkinson's, even dementia.
So why would a disease like type 1 diabetes increase your risk for a broken hip?
That's a great question because it's not just about fall risk. Research shows that diabetes can directly interfere with the actual structure and strength of your bones, making them more brittle.
Even if a bone density scan looks okay.
Even then, and then you have conditions like Parkinson's or depression that directly impact balance and gait, which just translates to a higher probability of falling.
Which makes the medication risk factor even more insidious because you're treating those diseases with drugs that might also increase fall risk.
Exactly. You have two things happening. Some meds, like long-term corticosteroids, directly erode bone strength. And then you have a whole class of psychoactive medications, benzodiazepines, certain antidepressants, antipsychotics, that affect coordination and balance.
They're critical for managing the condition, but they have the side effect of making you less stable.
It's a powerful connection that I don't think many patients are aware of.
Okay, so let's shift to what happens when that fracture occurs. What are the signs? It sounds like it's often immediately obvious.
It's typically dramatic. Severe pain in the hip, thigh, groin, sometimes even the lower back. There's stiffness, bruising, swelling.
And the person just can't move.
Yeah, move. Can't stand. Can't put any weight on it at all.
And then there's that striking visual sign, the one that often alerts first responders. The injured leg can look shorter.
It can, yeah.
What causes that? It sounds so traumatic.
It's the muscles. When the femur breaks, those huge leg muscles, like the quads, they spasm and contract violently. Since the bone isn't one solid piece anymore, that contraction pulls the lower part of the leg up and out.
Causing that shortening and external rotation, you see.
Exactly.
So if it's that clear from a physical exam, why do you still need a bunch of imaging tests?
That's a great question. The physical exam is usually enough to strongly suspect it, but X-rays are primary. They confirm the diagnosis and, crucially, tell you the exact location intracapsular versus extracapsular.
Which you need for the surgical plan.
Right, but sometimes for hairline fractures, an X-ray can actually miss it. Yeah, and that's when you'd move to a CT scan or an MRI for a much more detailed view to make sure nothing is overlooked.
That makes sense. So once it's diagnosed, it's almost always surgery, and it's fast.
It has to be. The goals are clear. Stabilize the fracture, get rid of the pain, and get the patient moving again as quickly and safely as possible. Delaying surgery beyond 24 to 48 hours is shown to really worsen outcomes.
Let's talk about those surgical options.
Yeah.
There's repair versus replacement. What does a repair internal fixation look like?
Well, if the bone pieces haven't shifted much, they might use individual screws, which is called percutaneous pinning.
Okay.
If the fracture is displaced, so the pieces have moved apart, they often need what's called an ORIF surgery, open reduction and internal fixation.
They actually open it up, realign the bones, and pin them with plates and screws.
Exactly. For the extracapsular breaks, where the bone is thicker, they'll often use a compression hip screw, or more commonly now, an intramedullary nail. It's a long metal rod that goes right down into the marrow canal of the femur. It acts like an internal splint, providing incredible stability.
But sometimes repair just isn't an option. That's when you move to replacement.
Correct. Especially if that blood supply we talked about is compromised. If that happens, the bone tissue will die. It's a condition called avascular necrosis.
Can you just break that down for us? Avascular necrosis.
Yeah, so think of your bone as living tissue. It needs blood. Avascular necrosis is just the death of that bone tissue because the blood supply has been completely cut off, the femoral head collapses, and you have no choice but to replace it.
So what are the replacement options?
There's partial or total. Partial is just replacing the ball, the head of the femur. Total replacement is more extensive. You replace both the ball and the socket, the acetabulum.
And total is better if there was already arthritis or something.
It's often the best long-term option in those cases. But there is a critical detail here you have to remember. Artificial joints have a lifespan, maybe 10 to 15 years.
So revision surgery is a real possibility down the line.
A very real possibility, especially for younger patients.
So beyond the surgery itself, there's the immediate care. Managing the fallout from just being immobile.
Absolutely. Besides pain meds, you'll see antibiotics to prevent infection, and critically, anticoagulants. We worry a lot about complications from the loss of mobility.
You're talking about DVT, deep vein thrombosis.
Exactly. Blood clots in the legs. Without movement, blood pools and clots can form. If one breaks free and goes to the lungs, it can cause a pulmonary embolism, which can be fatal.
So anticoagulants are non-negotiable.
They're critical risk management, along with worrying about pressure injuries, UTIs, pneumonia, all common when you're bedridden.
Knowing all that, knowing how devastating the complications are, it just brings us right back to prevention. How do we stop this from happening in the first place?
Prevention starts with some really practical, actionable steps. First, daily weight-bearing exercise, even just walking.
And then assessing the home environment.
Yes, actively looking for fall hazards.
I think we all overlook those. What's a common example?
Those little decorative throw rugs, they are absolute trip hazards, especially next to a bed or in a bathroom. Getting rid of those, clearing pathways, improving lighting, those are huge, easy wins.
And the third step goes back to the medication risk.
It does. You have to review all your medications with your doctor or pharmacist.
Yeah.
Specifically ask about side effects that affect balance or bone density.
And that includes over-the-counter stuff, too.
Everything, even sleep aids. And of course, the foundation is nutrition, calcium and vitamin D.
What are the specific targets people should aim for?
So for women past menopause who aren't on estrogen, the goal is 1,500 milligrams of calcium daily. For all other adults, it's about 1,000 milligrams with enough vitamin D to help absorb it.
Okay, this is where we can get into the high-value info on formal risk assessment. Beyond general advice, clinics use standardized scales to actually quantify a person's risk.
Right. It usually starts with a basic mobility assessment, checking gait, balance, ability to change position. But then we move to structured tools.
Like the Morse Fall Risk Scale. Can you walk us through the logic there?
Certainly. The Morse scale looks at 6 factors: a history of falling, having a secondary diagnosis, what kind of aid they use for walking.
A cane or walker.
Right. Their gait, how they transfer, and their mental status. But one of the most insightful factors is whether they have an IV or a heparin lock.
Wait, why is having an IV line a fall risk factor?
It's a physical tether, it's a distraction, you're connected to equipment, it restricts your movement, and you're preoccupied with managing it. It's a very practical flag for an elevated environmental risk.
And that all gets scored, right?
Yeah.
Low, moderate, high risk.
Yes, and each level triggers different care protocols.
Then there's the Schmid-Fall Risk Assessment, which looks at slightly different things.
It does. A score of 3 or more on the Schmidt scale means you're at risk. It assesses mobility, mentation so, confusion elimination needs, prior falls, and critically, current medications.
That current medications category must be a huge one.
It's probably the most powerful part of that scale. It specifically flags things that affect the central nervous system or blood pressure. Anticonvulsants, sedatives, hypnotics, even diuretics and laxatives.
It's a formal link between just standard chronic disease management and physical fall risk.
That's a perfect way to put it.
So that really brings us full circle. Hip fractures are serious, the risk factors are incredibly diverse, and surgery is pretty much always the answer.
And that surgery is just the beginning. Recovery is so tough. Only about 40 to 60% of patients ever get back to their baseline mobility.
That's a huge number who don't.
It is. And crucially, between 20 and 60% of patients who were totally independent before will now need help with at least one activity of daily living, an ADL.
That loss of independence is just devastating. Which brings up a final thought. Given that so many common drugs, antidepressants, antipsychotics, are explicitly listed on these scales as risk factors, what percentage of the general population is unknowingly carrying this elevated risk just through standard medical care?
That's the big question.
It really makes you wonder how deeply we should be integrating these formal fall risk assessments, like the Morse or Schmid scales, into just routine checkups. Even for non-orthopedic visits, it's definitely something for you to keep exploring.
Agreed. The breadth of the risk really demands a much broader approach to prevention.
Thank you for diving into the sources with us today. Until next time, stay well informed